Today, I will start this session by starting quality assurance in biochemistry. Now, why are we so bothered about quality assurance? Why are we always talking about quality? How does quality affect us in the lab? And we as laboratorians, what is our aim when we talk of quality? So when we talk of quality in the lab, we want accurate, precise, relevant reports, proper patient data for medical management of patients. What we want really in simple terms is total confidence in our report. The confidence should be shared by the clinicians, the confidence should be shared by the patient, and the confidence should be shared by all of us who are sitting in the lab. Second is to have quality and competence in laboratory services. When we talk of accreditation, we are laying a lot of stress in competence of laboratory services. And thirdly, which is most important and which is something which we must all now imbibe, is that we must align our day-to-day working, our test performances, all the QC policies and procedures of the lab with our quality goals. Now, when we talk of quality in the labs, there are two main terminologies which are usually used interchangeably, but we must be very, very clear as to what they are. First is quality assurance, and second is quality control. Now, what is the difference between assurance and control? And if you realize and remember the first slide, I spoke of quality assurance in the lab. Now, assurance is the practice of assessing performance in all steps of the laboratory testing cycle, which includes pre-analytical, analytical, and post-analytical phases, which are also now called the pre-examination, examination, and the post-examination phases to promote excellent outcomes in medical care. Now, to put it very simply, when we talk of quality assurance, we do not talk of only the testing phase. We are talking of the time and all the processes that are involved when the sample enters the lab to the time when our report reaches the doctor again. So all the processes that are involved, right from sample collection to transportation to reaching the lab to testing to release of report, all these processes are involved in quality assurance. When we talk of quality control, that control part is an integral component of quality assurance and is the aggregate of processes and techniques to detect, reduce, and correct deficiencies in an analytical process. Now, what do we mean by this? To put it very simply again, quality control talks of all the techniques, all the statistical procedures and processes that are used in the analytical phase, where our testing process is involved. And this quality control comes under the wide umbrella of quality assurance. Now, again, to bring about some specific important definitions which are required when we are talking of quality and testing in labs. One is accuracy, and the second is precision. Accuracy is the closeness of agreement between the result and the true value. That is, when we are testing in the lab, what is our result and how far is it from the true value? And this is checked by reference materials assayed by the reference methods. And second is precision. Precision is the agreement between replicate measurements, and this is expressed quantitatively as imprecision. So in other words, when we talk of accuracy, accuracy is how close we are to the true value. How close is our value in the lab to the true value? And this is checked by the reference materials which we are checking in the lab. Whereas precision is replicate testing. intra and inter precision, that how every time we repeat a test, how close we are to the replicate values. And this is what we do when we talk of standard deviation or coefficient of variation. Now, these days, we do not talk of just quality in a particular process or particular phase. The concept is of total quality management. Now, total quality management would include every aspect of the processes that we are doing in the lab, which would include the laboratory processes, our standards, the control that we put, how do we assess the controls, how do we plan on improving our day-to-day work processes, how do we plan for the future, the improvement, and how do we align our processes with the quality goals. So if we take what exactly is total quality management, first we would talk of the quality laboratory processes or QLPs. Now the quality laboratory processes would include our policies, our procedures, our standards, the physical resources that we use in the lab to get our day-to-day work done. Then it would include our quality control. Now quality control is the procedures for our analytical phase, for our work processes in the analytical phase. How do we detect the various errors and the problems that come while testing, and how do we make the corrections? And how do we find out about quality in the analytical phase? By using statistical quality controls. Different stats are used for monitoring the analytical performance of the laboratory methods. And what are these statistical formula that we use? We will come later in this talk. Third is quality assessment. Now, this is a very broad term. And in this, we assess broader quality factors like patient satisfaction, customer needs, our turnaround time, patient preparation, specimen acquisition, etc. So all these are part of our quality assessment, and our external quality assessment or proficiency testing was also included in this. Our next step then includes quality improvement, which is how to improve our current processes, that what we talk of continual improvement. Day to day, how when we detect our quality problems, what are these problems, what are the root cause analysis, how do we do our kappa, and how do we improve. Then we come to quality planning, which includes establishing and validating processes, how we will select new equipment for our labs, how will we select new test procedures for the lab, which is the best method, best kit to be used for these new tests, how do we validate and evaluate these testing processes, and how do we design our QC procedures for these new tests. Then we talk about quality goals, which are the requirements that, what are the requirements that we need to achieve to satisfy the needs of the customers. These days, our customers are also very, very particular and very, very picky. They will come and tell you that this is not the report that we want. The other lab gives this kind of a report. We want this from you. So what are our quality goals? How do we improve our testing procedures? How do we improve our reporting format so that the customers are very satisfied with our lab? So all that comes in, it gets included in total quality management. Now we come to the errors in the lab, that when we are talking of testing in a lab, how will we test in the lab? What are the errors we look for? What are the different types of errors that can happen in the lab? And then how do we identify these types of errors? So when we talk of biochemistry especially, and also all other aspects of lab testing, there are two major types of errors, which are random error and systemic error. Now, random error, as the term implies, is random. It could suddenly come and suddenly go. You cannot expect it. It is a sudden variation on either side of the mean. So a random error is a sudden variation which can happen in which your QC can go either above the mean or below the mean, and it is reflected as imprecision. That is, how do we measure random error? By through the deviation that can occur in the standard deviation or in the CV. Now, in the testing processes, it could be a sudden error in the temperature, a sudden fluctuation in the voltage, a pipetting error that can happen. All these would be defined under random errors, that these errors do not normally happen, but can suddenly happen once or twice randomly. The second type of error that we talk about is a systemic error. Now, a systemic error is a variation which happens in one direction from the true value. And this error is not a random error. It doesn't happen just randomly. It is happening over a period of time. And this can be reflected as a trend or a shift. If there is a sudden shift and carries on for a long time in one direction, or it could be a slow increase which is happening over a period of time. And a systemic error is generally reflected as a bias. So if here we will see that these are random errors. It could happen anywhere, anytime, on any side of the mean. Whereas when we talk of systemic errors, this is happening on one side of the mean and over a period of time. So this is called a systemic error. And this is a diagrammatic representation of a random error. Now the question arises, how do we recognize that it has happened as a random error or a systemic error? So the best way to detect these errors is through our LJ charts. If we can look at our LJ charts daily and see the reflection of our quality control of that day on the LJ charts, by going over the Westgard rules, we can easily detect whether it is a random error or a systemic error. So when we talk of a quality control assurance program, we would be talking about the internal quality control, the external quality assessment scheme, the inter-laboratory comparison, and certain alternate approaches. And in each of these, so there are 4 basic approaches in the quality assurance program. The daily internal control, the IQC that we run, that is called IQC. The monthly or the bi-monthly or the quarterly international or a national assessment scheme that we do with the external laboratories, that would be part of the IQAS. Then we talk of the inter-laboratory comparison if an IQAS is not available. And if any of these is not available, then there would be certain alternate approaches that can be used. Now, the important thing for all IQC, IQAS, ILC and alternate approaches is that we do not worry if there is an outlier. There would be an outlier, yes. What is important is that we do a root cause analysis with a corrective and a preventive action. So the important aspect in this is not to hide or not to get very worried that we've got an outlier. The important aspect is that we do a root cause analysis and a corrective and preventive action is taken to avoid these errors happening again. So coming first to the IQC or the internal quality control. Now IQC is monitoring of the test performed in the lab. All of us know what IQC is. We all procure the internal quality controls from various agencies. They are run daily as per the rules that are formulated by the lab or by the agency, accreditation bodies. It could be daily, it could be as per the latest guidelines given by NABL 8 hourly if it's a 24-hour lab, or as per the rules, the policies and procedures defined by the lab. Now we all know that these are run daily. It could be run multiple times daily, and a statistical analysis is done at the end of the month. The LJs are checked, and the aim of the IQC is a continuous evaluation of reliability of results. And what is our aim of doing daily IQC? IQC primarily checks for precision. So this is something we must all remember, that when we are running IQC daily, the aim is to check for precision. Now we are using control materials daily. These control materials are pools of biological fluids, and the aim of these IQC is to be as close to the matrix of the sample that we are testing. Only then can we get values which are closest to our true value. So we would want to choose, using the IQC material, we would like to choose the basic material of the IQC, which is as close to the matrix of the sample that we are testing. So if it is serum, then it should be a IQC which has got a matrix similar to the serum. If it is to the urine, then we have urine controls. Now we even have controls for various fluids like CSF. So that is what we must look for. The second thing is the different levels of controls. Now, what do we mean by levels? Internal quality control material comes at different levels. Now, when we are giving the patient reports, there could be low level of reports. Then we have levels which are close to the normal level, the normal biological reference level. And then we have reports which are very high. So what we are looking for in our internal quality control is different levels which could be low, medium or high, so that we can run controls and get to know about all ranges of our patient reporting. Of course, it is very important to be very close to the critical or the decision level of the reports also. Now, when there are sometimes when we find people, for want of availability or for want of even monetary and financial consideration, sometimes certain people would say we will get only one level of control and we will run only one level daily. It's coming all right. Now, would you accept that? Preferably, we would like the labs to use different levels of controls so that we realize that whether when the lab is giving lower values or the lab is giving higher values, or if it is giving at the biological reference interval values, our controls should cover the entire spectrum of the range so that we get that confidence and that all our reports are absolutely reliable and are absolutely precise at the entire spectrum of the values. Third thing that is important in control materials when we are talking of IQC is that the control limits. We have to define the lower and the upper control limits. That is that we have a mean value or an absolutely true value which is given to us with the internal control. And when we run our control, it should be, of course, the best case scenario is that we are absolutely on the mean value and we are very happy that our control levels are on the mean. But practically we know that this never happens, that our value will always fluctuate a little on the negative side or the positive side. That is a little lower or higher than the mean. So we have to define limits, whether it is 1 ST. Normally what we do is that 2 ST limits are defined so that we know that between these limits, if our control values fluctuate, we are all right, we will accept it. And beyond which level for which analyte are we going to reject the rules. So when we talk of control limits, and I had earlier spoken about random error and systemic errors. How do we define these control limits? How do we come to know that when we are running our internal controls, what is a random error, what is a systemic error, what are the control rule violations, how do we reject them, how do we accept them, and what is going to be our policy to accept the controls or not. So for that, we take help of Westgard rules. Now, quickly running through the Westgard rules, because I'm sure all of you must be very familiar. These rules are very, very important in biochemistry. So I will do a quick run through about what is Westgard rules. One of the most important rules that we take are the 1-2s rule, where the one value is above um, two standard deviation. So it's called the 1-2s rule, and this is considered as a warning rule. So we normally do not take it as a rejection rule, we take it as a warning rule, and we check the controls carefully. When we get 1,3s, that is one value which is more than 3 SD, that we take as a rule for rejection, and this 1,3s rule is taken as a random error. Now, another rule that is normally taken is 2,2s. When we get two values which are on beyond 2 SD, it is on the same side of the mean. It could be plus 2s, it could be minus 3s. This is a systemic error. And then we have an R4s rule, which is a plus 2s or a minus 2s. The value is beyond plus 2s or beyond minus 2s, and this reflects a random error. Then we could have a 4-1s rule, which also reflects a systemic error, or a 10x rule, which could be a systemic error also. So these are the common Westgard rules which we take to design, which are designed to detect errors. Now, as I have just said, random error would be an inconsistent change which would affect the precision and would be expressed as a CV, because this is affecting the imprecision. And imprecision is always given as standard deviation or a CV. Whereas a systemic error would be a consistent change. It could be reflected as a shift or a trend. And this is expressed as bias. So the Westgard rules that we spoke of, how does it tell us? How do these rules tell us that what we have now seen as an outlier in our LJ chart, what kind of an error is it? So if there is a 1-2s rule, we would take it as a false rejection. We would look very carefully, run another control, or keep the other controls under observation and check whether there is a trend or a bias. Now, when we get a 1-3s or an R4s, that we take as a random error. And when we have a 2-2s or a 4-1s or a 10x, these rules reflect a systemic error. So our root cause analysis should be on those lines, and should look for these outliers. We should look for random errors. For these, we should look for systemic errors. This is how these Westgard rules and our LJ charts help us in detecting the type of errors and in doing our root cause analysis thanks to our Iqc that is run daily in the lab. Then we come to EQA, or external quality assessment. Now, external quality assessment, as the name suggests, is run through an external agency. It is performed at regular intervals. Those regular intervals could be monthly, it could be quarterly, it could be bi-monthly, it could be every 2 monthly, depending on the agency. And the frequency depends on the scheme and the company that is running it. A sample is prepared by the particular agency. It is sent to all the labs, which could be international or national, and the results are collected by the company, the agency, at the end of the month or at the end of the quarterly period, depending on the period, and the results are then again statistically evaluated and compared. So aim is to give to achieve between lab and between method compatibility, because they will tell you, as I'll come to the later slides, between lab and between method compatibility. So what are the main objectives? Why should we spend money and precious time and resources to do external quality assessment, because they help us to establish an inter-lab comparability and they tell us about the accuracy. They influence the reliability of future testing and ensure the quality and credibility of the laboratory. Now, when we talk of PT reports, there are certain components of PT reports. Now, some I've just collected from various things. This is not any particular company or agency. I have just tried to put in whatever is available by different companies. Now, generally what is given is the Z-score or the standard deviation index. A percent deviation is given, a coefficient of variation percent is targeted, and some also give a target value. We get a report like this where you will be given about your method and your particular your method and your instrument, or it may be all methods, or there would be a group, the third group, where if you don't fit into the first two groups, you will be compared with everyone, all of them. So that is what is very important, that first is your peer group evaluation, then is your method evaluation, and third is the all method evaluation. Then they give a text section. The text section would provide a breakdown of the statistical results by all methods. Again, as I said, here they would give all the methods and would give the standard, your value, the target value, the standard deviation, the coefficient of variation, etc. Then you are given also the percent deviation. How much is the deviation from the mean? Then a Levy-Jennings chart is given where they would plot it with the mean and would give the control values, the two standard deviation, and the last 20 odd values are plotted. A histogram is also usually given where they would plot all the labs and your values and then explain also where in this your lab would be following. If it is, and they would give, if it is here, you would know that you are in the middle somewhere and you are all right, doing well. Or if you are somewhere which is totally outside, then there is cause to worry. Some labs also give a target score, where the target score would some companies in their reports would give a target score, and they would also tell you again whether this would be the perfect 120, which is perfect, and these are unacceptable. So if the value is coming here, it is totally unacceptable. Then what is most important is a summary page. Most of these companies give you a summary page where they will give you a mean for comparison, give your result, a standard deviation, etc. So you can at a glance get to know whether your report is all right or not, or whether you are out. So if the result is unsatisfactory, what do we do? The basic aim here is to prevent a second unsatisfactory performance. So for that, we have to become proactive. We have to make sure that we do a root cause analysis. Since an Iqc result is a retrospective analysis, this is very important for us because we will be getting the result 1 month. It's a monthly examination. We are sending it monthly. So by the time we get the results, it's another couple of days after sending the results. So when we get our report, we have to do a retrospective analysis and check, do a root cause analysis as to what happened to the Iqc that day, what happened, was there any random or systemic error, what was the problem, and do a corrective action. And that is the very, very important aspect of an external quality assessment. So initiate a corrective action. So, and what is a corrective action? The aim of this is to make sure that we do not repeat the error again. So the benefits of doing this Iqc is to allow comparison of performance and results among different tests worldwide, if it is international or nationally. It warns for systemic problems associated with kits or any operations. gives you an objective evidence for testing quality and indicates areas that need improvement, and if required, we need to improve our training or not. Now, what happens if we do not have an equa for a particular analyte? There are certain rare or analytes which we may not have an equa, or it may be just, it's a very low volume parameter for certain labs, and the equa is very, very expensive. They cannot, for financial reasons, go for it. So what do we do then? In such a case, we will be very happy to do an inter-laboratory comparison. Now, as per ISO 15189-2012, what is an inter-laboratory comparison? ILC or ILC? That is an organization, performance or evaluation of measurements or tests on the same or similar items by two or more laboratories in accordance with predetermined conditions. That is, a lab would like to send to one or another lab or more labs to check their result. And what is very important is, which the lab must see, is that you have to define the acceptability criteria for each parameter. Just sending your sample and to another lab, getting the report and filing the report is not enough. We have to define the acceptability criteria for each parameter. Then we have some alternate approaches. If ILC is also not feasible for whatever reason, then there could be some alternate approaches like split sampling or retained sample testing, or taking some older equa samples and doing it. But here again, we have to check for the stability of the analyte, right? We must check for the stability of the analyte. Now, we have spoken about IQC, we have spoken about equas. All these reports require certain statistics, because without these stats, our daily IQC or our daily or a monthly equa is of no use to us. So there are certain stats which are done daily, which I'm sure most of you would be familiar with. The simpler ones like mean. All of you know is that we take out an average or a mean of all the data points of which we run of the IQC at the end of the month. Similarly, you get the mean by the equa agency also. Now, it is the best estimate of the analyte's true value for a specific level of control. And what we do in our lab is, at the end of the month, we take out a mean and then we check a plus minus and normally a 2 SD range, which is made by the lab, and in this range, all results are accepted, and anything beyond this range, we reject it. Then we talk of standard deviation, and as I said before, the precision, or when we measure imprecision, we take standard deviation. Now, standard deviation is important for tests which are repeated regularly on the same patient. For example, now a diabetic patient, he comes first time to the lab and his sugar comes at around 400. He goes to the doctor, starts getting treatment. Next time he comes, it is 300. Then it gets controlled to 200. Then it gets controlled at 180. Then the doctor tells him, now every month you get it checked. And then once you have your medication is standardized, then you monitor yourself 6 monthly. So this patient keeps coming to the lab at regular intervals. So it is very, very important for the lab to make sure that the tests which are repeated regularly, the precision is very, very good. So this is why it is very important for us to check the standard deviation and maintain very, very strict limits and make sure that we are complying to the limits. So a high standard deviation could be due to inherent variability in the test, or an analytical system malfunction where the deviation is very high and which the lab needs to investigate and correct. Then is a very common thing that we check is an SDI, which is normally given to us in our equa reports. Now, what is SDI? SDI would be the mean, the lab mean minus the group mean upon the standard deviation of that particular group. And when we talk of a standard deviation index, if it comes 0 is the perfect SDI. That is, the comparison is perfect. And here again, normally what we take is plus minus 2 SDI. Anything, nowadays some labs take 2.5 or even 3 SDI. That is dependent on the lab's policies and procedures and the parameters, how critical they are. And anything beyond 2 or 3 or 2.5, depending on what the limit set by the lab, a review is performed. Bias is again a measure of a systemic error, and it shows how far your value is from the target value. So these are the formulae which are given for bias percent. Then we have another thing which we do very commonly in the lab, and that is coefficient of variation, which is a very simple measurement of a standard deviation divided the mean into 100. Now the question arises here is, why do we need to do a coefficient of variation when we are already doing a standard deviation? We have a standard deviation that is telling us the deviation and the error that is happening. Then why do we need to go on for a CV? Now what happens is, a CV is an accurate comparator of the precision of two analytical systems. Now some values, maybe the units are different. Some would be in units per liter, some would be in grams, some would be in milligrams per deciliter. So if we want to compare by 1, we would take it as a percent. So the aim of calculating CV percent would be to have all our variations in a percent, so we can compare it. It makes it easy. And again, smaller the CV, the more reproducible the results. So if our CV is anything less than 2 or 0.5, 0.3 or something, our testing system is very, very precise. Now there is something called as total error and total allowable error, which total allowable error is the analytical quality requirement. So they set a limit for imprecision and bias, which is tolerable for a single test run. And we have certain allowable errors which are given to us also, which are available on the net easily by CLIA. Now CLIA gives it, CLSI, PT providers, all of them also give certain total allowable errors, which are different from different analytes and includes both bias and CV. So these can also be taken from the net and calculated for the different parameters in the lab. Now a lot is being talked about these days about Six Sigma. Six Sigma is considered now the future, and probably we will be all shifting to it soon. Sigma metrics also is used for quantifying the test performance. And Sigma metrics takes into account both the total allowable error and the imprecision, the bias also, and the standard deviation. Now, how will Six Sigma, which is normally used in industry, how does it help us in the lab? When we talk of sigma values, lower the sigma values, more the QC rules that we need in our lab and more the QC samples. Whereas now Westgard on his site has given us that initially it given us Westgard rules. And according to those rules, we had defined our various Westgard rules which would help us in detecting a systemic error or a random error. But in today's kind of auto analyzers that we are using, where the bias is almost negligible, where we have state-of-the-art technology. So sigma metrics can help us choose QC rules depending on the sigma that is calculated for each parameter in the lab. And we can reduce or increase our QC rules and thereby minimize the use of controls in our lab. So as per Westgard, he has said that if the sigma is more than 6, we can minimize our QC rules, or if it is less than 3.5, then we have to use the maximum affordable QCs and have a multi-rule. So as per this chart that he has given us, depending on the sigma that we calculate for each parameter, we can reduce or increase our QC rules to give us more confidence in our test results. So to conclude, I would say that the quality management procedures that we adopt in the lab would give confidence to the labs on the performance and the reliability of reports, and it would really help labs in seeking accreditation. It would give us a careful interpretation of the various existing control data, aided by additional control rules if required, and give us a sequence of rules to help detect the various errors. So, with that, I would like to thank you very much.
And good evening, everyone. So today's my topic is on quality control in histopathology and cytopathology. And as we all know that this is a subjective discipline, and we shall not be dealing with the numerical values for the quality control as we see in case of hematology and clinical biochemistry. Let's start with, first of all, the quality assurance in histopathology. So, histopathology is basically an art of analyzing and interpreting the shape, size, and architectural pattern of the cells and tissues within a given specific clinical background, and a science by which the image is placed in context of knowledge of pathobiology so that we arrive at an accurate diagnosis. The quality assurance definition as defined by the CAP is systematic monitoring of quality control results and quality practice parameters to assure that all systems are functioning in a manner appropriate to excellence in healthcare delivery. Now, what does that mean? And how do we simplify that? So let's come to the next slide. So actually, this is a fact that assessment and implementation of the quality control is actually more difficult in histopathology because of there is definitely lack of the objective numerical data. There are descriptive nature of the reports. There is definitely subjectivity. Some people may find it benign, while some borderline, some might call it malignant. So subjectivity is very much there. So individual judgment has got a very big role to play in histopathology. And there is a lot of reporting patterns which are existing in the histopathology industry. So all these give rise to quality control is very difficult. However, there are some variables. If we will take care of that, we can definitely take care of the histopathology quality. What are those? Educational background and training of the laboratory personnel is very important. What are the specimen we are using? The condition of those specimens, controls used in the test runs, reagents, equipment, interpretation of the results, transcription of the results, reporting of the results. These are all the variables which can, if we'll take care of them, our quality definitely will be good. To simplify further, let's divide these variables into the three phases as we do in pathology or laboratory. Pre-analytical phase, analytical phase, and post-analytical phase. That means the phase before we testing, I mean, is dealing with the specimen, and then comes the analytical or examination or the testing phase where we are actually performing the test, and then comes the post-analytical, that is once we have finalized the report, how we are going to take care of that. Now let's talk about the pre-analytical phase. Now all the processes involved up to the submission of the stain slides in histopathology for analysis can be grouped under the pre-analytical. So it will include infrastructure, manpower, equipment, sample collection, requisition details, correct demographics, transportation of the samples, and histopathology fixation is also a very important aspect of the pre-analytical phase or about the specimen caring. Now, as we say, even about the blood sample or urine sample, or for that matter, any sample in the laboratory medicine, labeling is the foremost important thing. Majority of the errors in the laboratory occur in the pre-analytical phase, and this is the known fact. Therefore, correct patient identification by a unique accession number, which we call the unique patient's ID, and that must be traceable to the specimen, and report all through the process is very, very important. Avoiding errors such as the wrong identification of the anatomical location, as well as the literality of the biopsy, whether it is right-sided or left-sided, is also very important. In histopathology, and for that matter cytopathology also, the requisition details are to be correctly captured. So the referral forms have been developed, which we call it requisition form also, and they must be available at any place from where the samples are collected. I mean, they should be available in the operation theaters where the samples are biopsies or some operations suitable for the later on for the histopathology samples are carried out. Now this form must be carefully filled up with all the relevant clinical data and patient demographics. For simplification, there can be some check boxes which should be ticked correctly. If the form is not correctly filled up, we can always have a dialogue with the clinician, and so that we can derive the proper information. And in sometimes in the hospital settings, we have the clinical data available in the hospital files or in the system of the patient, and that can be accessed, and wherever possible, all the clinical context must be derived before reaching out to any diagnosis. Now, there are some steps in the pre-analytical and analytical process. Now, we must develop the standard operating procedures for the sample accession, identification, acceptance, rejection, gross examination, and sampling. All the steps must be documented. So the very first step is that we make the proper SOP regarding this, and these SOPs must be available at the point of use so that it can be anytime accessed by the staff, and it must be written in a simple English or in a language so that it can be understood easily. In histopathology, we are frequently using the chemicals. Now, chemicals are used for processing. Now, without going into the steps how the processing is done, from quality point of view, it is important that we have a proper SOP regarding the processing also, so that there is no under processing or unnecessary rework or loss of tissue. The same also applies when we are doing deparaffinization, staining, dehydration, and clearing steps. Fixation is another, as I said earlier, is a very important aspect in the histopathology. What are the fixative agents which we are using commonly is 10% formal saline, 10% neutral buffer formalin. That is recommended particularly when we also want to carry out the immunohistochemistry. And fixation must be done immediately after surgery to prevent any putrefaction changes. What should be the volume? Volume should be the 10 to 20 times the volume of specimen. If there is a larger specimen, like breast specimen, it must be sliced and then kept under the formalin for fixation. If there are large specimen like intestine, it must be covered with cotton wool soaked in formalin. And as we all know, the bovine fluid fixative should be used for the testicular biopsy. Equipments are very important, not only in clinical biochemistry or hematology, it's equally important in histopathology to get a good sections. One of the most important equipment is microtome, which must be serviced regularly. And if the micrometer is attached, periodic calibration of the same should be done. Periodic cleaning and lubrication of the equipment is also important. While doing the tissue processing, care should be taken not to induce tissue artifacts due to improper processing, sectioning, staining, and mounting. And as we said earlier, labeling of the stain slide must be done very carefully and correctly. The controls should be used wherever required. Controls, for example, even for the routine H&E staining, laboratory may identify one tissue block with a good mixture of hematoxylin and eosinophilic tissue, for example, the cervix tissue or the fibroadenoma as a control for H&E staining. And if we are doing even for the spatial stains or immunohistochemistry, it is must to use the controls side by side. It is something like that we use the quality control materials in hematology and biochemistry, and similarly same pattern. However, there is no numerical values. We use the control part while doing the spatial stains. Post-analytical aspects are also very important. The most common aspects of the post-analytical phase involves report generation without any transcription errors, report transmission or dispatch to the right person or persons, storage of the reported material as well as the reported data, and safe disposal of the specimen thereafter are the important aspects of the post-analytical aspects. Another important thing in any pathological testing is about the TAT or turnaround time. And so it is also equally important for the histopathology as well. Monitoring of the TAT is of vital importance, and laboratories should strive to achieve the goal of signing out the most cases within the recommended TAT. There could be some cases which will definitely go out of the TAT, as we all can understand, and it is because of the complexity of the diagnosis. And then we have to read different books, then it can take, and that can be always explained to the clinicians or to the users. If we use microtime, we can definitely reduce the time particularly for the small biopsy, where the fixation will be fast and very good, and in a little time the sectioning can be done. The TAT of the frozen section should also be monitored, and the retention period of the specimen after reporting should be as per prevailing guidelines. One can refer to the specific criteria of NABL 112 also for the retention time. Audit is another important activity to maintain the quality of any department of the subject. It must be done independent of the activity. So the person who is reporting histopathology should not get involved in doing the audit of his own. The best thing is to call the histopathologist from the other places to do the audit, who was also aware of the 1518 standards and as well as possess the knowledge of the subject. Inventory management must be done very carefully. Stock registers are to be maintained. Archiving and storage has got very important role in histopathology. The block should be preserved in a cool place, and there should not be any deterioration of the blocks because the long storage is required, particularly for the histopathology blocks and slides. Reporting should be done without any error or without any transcriptional error. Another important aspect is about the quality assurance, that is the participation in the proficiency testing. Now, proficiency testing or the Iqc program, as Dr. Anjali has told in details in her talk for the quality in biochemistry. Now, similarly, there are proficiency testing programs which are being run by the different agencies in India, and lab must participate in that. It will definitely tell you how you are performing with respect to your peer in the industry. Even if you are not participating in the proficiency testing program, inter-laboratory comparison can always be carried out. Any tissue which is subjected to the frozen or the cytology must be compared with the permanent section or the histopathology. And one should analyze if there is any discrepancy, what is the reason for the wrong diagnosis given on the frozen or cytological cases. Then there can be a random case review, or this can also be called the blinding re-reported of the random cases. So what are the cases which have been reported earlier, randomly it can be taken out and then without looking at the report, and then should be reported again. So it can be reported by the same person, which we can call precision, and by the different person and something we can call for accuracy. Terms which are not used as such in terms of in histopathology, but just for the comparison sake, I have used the same. Interdepartmental consultation can also be, so there can be some cases which are reported by one particular pathologist, then can again be reviewed by the colleagues who have not reported the same. There should be hierarchical form of reporting, and so whenever any complex case comes in the department, must be seen from junior to the senior level and then collectively signed, so that the chances of wrong reporting is minimal. In histopathology, it's very important that we maintain a good rapport with the clinician, and we must use clinico-pathological meeting to ensure the diagnostic accuracy, and uh, so that any gap or lacunae between the pathology and clinical details can be made out. One must audit the how much slides are being screened by the one pathologist. There should be even distribution of the departmental overload. As we all know, we are all human beings. If the one pathologist is overloaded with the slides, we all can make an error. Then we can always have a review by the external consultants. We can have reviewed by the experts in some, for example, there could be someone who's experienced in lymph node or can be in CNS. We can always review the cases pertaining to them by those experts. And of course, as we always say, we all must participate in the CME program, and that definitely gives us some insight about our subject. Now coming to the cytopathology part. Now, as we said in the histopathology, now similarly for cytopathology, again, we can simplify the quality in three phases: pre-analytical, analytical, and post-analytical. Now, in cyto also, it is very important that we take care of some variables. What are those variables? Reagents, equipment, reporting, quality control, proficiency testing. Now, what are the equipments which we use? So we are using, for example, for the LBC machine, we are using cytocentrifuge, particularly for centrifuging the fluid specimen and making the button out of that. So it's very important that we get our cytocentrifuge calibrated at the required frequency every time. Now, in pre-analytical aspect, sample collection, as we said during the histopathology, that sample collection, there should be clear labeling with the patient name, ID, and the source of the samples. Samples at no time should be left unlabeled. Whenever any FNAC is performed, immediately with the diamond pencil, the ID or the name or the should be written on the slide immediately, and the same should also be written on the requisition form. Sample requisition form must be filled up with all the details with correct demographics, and we should never forget to write the side from where we have done the particular procedure, whether it's right side or the left side. We tend to forget that at the time of doing it, and then we don't write it, and then while reporting, then we wonder which side it was. Similarly, the requisition form coming from the radiology for any guided FNAC, whether it's ultrasound guided or CT guided, that should also write their imaging findings. If the same patient sample has come for the second time, then the previous cytopathology number should be written on the form, obviously for any reference, particularly whenever the pathologist needs, particularly for the sake of comparison. Relevant clinical history definitely is mandated on the form. It is very important that we write the proper history and the site. Ductal cells will look alike, whether it is from the breast or salivary gland or any other gland. We must have the proper site locations. And if we have done the FNAC ourselves, we must ensure that we have correctly written the site, any history of medication, clinical diagnosis, date and time of collection. And whenever we have some imaging findings or radiological finding, we must mention that on the requisition form, so that while at the time of the reporting, we can easily understand that. If the pap smear, again, we should have some details like date of the LMP, previous abnormal report, treatment or any biopsy information, detail of hormone therapy, details of contraception, details of previous surgery. So as we all know, while at the time of reporting, how important is this? Some of the other important aspects in while doing the PAP, one slide must contain the cellular material from the endocervical canal and cervical transformation zone, because this is the area we would like to see in the form of the cells on the slide. For the nipple secretion, the rapidly smear secretion on the slide and prepare both air dried and wet phase. Wet fixation is a good idea if we make the two sets of slides, one air dried and another we fix it immediately. Sputum should be collected after the deep cuff so that we get the cuff specimen as proper sputum specimen, and it must be submitted at the earliest to the lab to prevent any degenerative changes. Any fluid sample for that matter should also be submitted at the earliest to the lab so that again we avoid any degenerative changes. Buccal smear must be taken after rinsing the mouth properly with water, and then we should scrap the inner surface of the cheek along the buccal surface. And it must be smeared very quickly and then fixed. Most important fixative is 95% ethanol, which works very well in the cytopathology. While doing FNAC for the small subcutaneous lesion, 2.5 centimeter long 23G needle is good enough. If it is deeply seated, then long needle can be used. For soft fleshy lesions like lymph node, 20G needle can be used. For serous lesion or fibrotic lesion, small gauge needle 23G can be used for the better penetration and less trauma. So it is a myth that if we use the bore wide needle for the serous or for the wider lesion, we will get more tissue. In fact, we will induce the more trauma and we will make the diluted smears. Even for the vascular lesion like thyroid, small caliber needle should be used, and negative pressure application is not needed because it's so vascular. The blood will automatically flow in and will get the good material which can be smeared on the slides. For a cystic lesion, we can use, if we want to aspirate the good amount of fluid, then the large carriable needle can be used. Otherwise, for guided FNAC, again, we can use the long needle to go deep inside, and 20 Gs can be size can be used. Now we must carefully accept and reject the sample depending upon the acceptance and rejection criteria. Some of the causes for the rejection cytopathology include unlabeled sample, mislabeled, empty vial, or irreparable broken slides. In analytical phase, it's very important that we keep a full log of the processing of the fluid sample. So we should have a good idea how much samples or slides we are going to process in that much fluid, and it should be then changed regularly. Sample received during the daytime should be submitted fresh and without any fixation. Sample submitted in the night should be fixed with equal volume of 50% ethanol and refrigerated. And specimen with the high protein contents can be preserved for 12 hours if it is refrigerated, and sample with high protein can be preserved for 12 hours if refrigerated. A specimen like CSF and urine should be processed immediately if submitted during the night time. Then cytospin or centrifugation must be done, and both air dyed and wet fix should be made. If there is a lot of blood, it can be hemolyzed by adding 1 ml of glacial acetic acid to the 50 ml of sample. After that, erythrocyte hemolysis after slide preparation, and there is a proper procedure. I'm not going into details of that. So what I want to say is that whenever we get, according to the nature of the sample, it should be processed, whether it is hemorrhagic or not, and the time is also very important. If we really want to keep the sample for processing it later, we must fix it with equal amount of 50% ethanol, and we must refrigerate it. For all exfoliative cytology, pepinoculose stain must be used. FNAC must be stained with at least 2 stains with either MGG with PAP or HNE. And we must have an SOP in place, as we were saying during the histopathology, and it should be available at the point of use. We must take the particular precaution with pH of the buffer distilled water, which should be 6.8, and we must keep on checking the pH of the diluted buffer distilled water while doing the staining. Special precaution must be taken that slide should not be promoting alcohol solution for longer time. After OG and eosin dye, as the stains have penetrated, the cells will be washed out. When the slides are transferred from water to hematoxylin, the glassy droplets of the water on the slide must have disappeared. If not, hematoxylin will not penetrate the nucleus and the cell may appear healthy. Gynecological and non-gynecological stains should be stained separately. Check the pH of the tap water or the ammonia solution following hematoxylin staining to ensure that it is sufficiently alkaline, as alkalinity is required. Post-analytical, as we are disposing of the samples, whether histo or the cyto, we must comply with the existing biomedical waste guidelines. We should store the sample for at least 24 hours at 2 to 8 degrees Celsius. And as per the guidelines in India, we must keep the cytopathology slides for 5 years, and we must keep them in a proper slide cabinet to prevent any deterioration to them. And it must be, all slides must be retrievable. So that retrievability is also one of the important aspects of the quality parameters. And we must ensure whenever we are opening any new lot of reagents or stain, we must first stain the slides to check whether the staining or the reagents is working fine or not. We must maintain a log of all the reagent change frequency to be decided according to the workload. As I said, equipment like cytoscreen must be calibrated. Reporting is also one of the aspects of the quality, and we must report according to the latest prevailing guidelines and nomenclature. For example, pap smear should be reported as per the Bethesda system. Comments should always be made in our report. We must make a comment about the adequacy of the material, and some of the recommended reporting nomenclature include Bethesda classification for gynecological pap smear, Bethesda classification for thyrocytology, Paris classification in urine, Milan system in salivary gland cytology. And as we said, the TAT must be defined for all cytopathology report. Whenever we are getting any unsatisfactory or equivocal, we must give our right either comment why it is so. And we must recommend what further can be done, whether the biopsy examination or histopathological, whatever. For the quality control parameters, if gynecological screening slide is seen by the trained cytotechnology, which is usually not the case in our country. However, in that case, 10% of all negative smear must be reviewed by the pathologists or cytopathologists. Rescreening of the previously reported slides on receiving the fresh smears from the same patient during follow-up and review report of the same is to be mentioned in the current report also. Records of checking the quality of staining, which is to be done every day whenever any new lot of stain is open. Avoid over-screening of the slides by cytopathology. If we have to define, then it should not be more than 100 slides in 8-hour duty. Follow-up of the cytopathology cases with biopsy, endoscopy, histopathology record must be maintained for cytobiopsy or histocorrelation. It is must and one of the quality indicator in cytopathology. If any discrepancy, then slide must be reviewed for all learning purpose. What was the reason why we have not given the correct cytodiagnosis in the first instance? Peer review, as we said during the histopathology, peer review can be made, and then the slides can be reviewed by the peer, and then again we can assess them. Some of the quality indicators which must be followed in the gynecological cervical screening include number of atypical squamous cells percentage of the atypical squamous cell as equals to the total number of atypical squamous cell, number of the squamous intraepithelial lesion, and ASC SIL ratio. And laboratory must perform, as we said during the histopathology, must perform in the PT program. On receiving the results, slide must be reviewed for the wrong diagnosis made. Record must be kept for the action taken for the wrong diagnosis. Any good cytopathology cases can also be sent for the interlaboratory program, and record of the same must be maintained. Staff must be trained on the various SOPs, techniques, training schedule must be made, and pathologists, as we said, must attend the CMEs to keep abreast of the knowledge. So in summary, sample collection to be proper for all cytopathology specimens, SOPs must be made, equipment must be calibrated, staff should be trained, requisition form must be clearly filled up, reporting should be done according to the latest system for reporting, quality indicators for the PAP screening must be evaluated annually, quality control program is to be designed, and laboratory must participate in PT or ILC program. Thank you very much.
I have tried to make it as simple as I could for everybody, and I will walk you through basically the Iqc plan for a microbiology lab, where I would primarily be covering the microbiology part of it. I wouldn't be covering molecular and serology because again, they are by themselves another topic. So I'd be doing hardcore microbiology. So most important thing is, why do we need an Iqc plan? Why do you want to do it? What is the requirement of an Iqc lab for the lab? So for the microbiology lab, or in fact for any lab, the first and foremost reason is we all are giving patient reports. So we have to stand by our reports. So it basically gives confidence in the day-to-day performance of a lab, what method you're following, what reagents you're using. And how do you get this confidence? By the reliability in the reports. Today, if I report an organism as E. coli, tomorrow also I'll report it, or you will report it, your lab will report it as an E. coli, irrespective, in fact, of the microbiologist who is reporting, because there's a component of the, in microbiology also, the personal reporting, the person who's reporting the test. Plus, it also helps to appraise the safety and quality in the lab, the safety practices, etc. So this makes basically the functioning, the general operation of the lab robust. I always say quality is a part of efficient operations. If your quality is good, your operations will always be efficient. Then how to design an Iqc plan? It is important, many people get confused. It becomes haphazard. You don't know from where to start. So it is very important to decide what has to be included in Iqc plan and what has not to be included. And you need to plan that out. Once you plan that out, you document that in the form of a SOP, in the form of a workflow, depending on where you're doing it, whether you're putting it on the bench top, you're making an SOP, and then define clear-cut criteria for each thing. I will be coming up later on how you can set up your criteria. And you need to follow certain standard guidelines or standard textbooks or standard white paper. You just can't say that I follow this is the breakpoint for an antibiotic. It was published here. So you need to have a robust reference for whatever quality practices you are following in your lab. Now, what are the phases? How will you design? The most confusing part is from where do you start your quality practices. So best is to divide your processes into pre-analytical, analytical, and post-analytical. The pre-analytical obviously is directly related to the test ordered by the clinician, the patient, the collection, and the transport of these samples. Obviously, analytical part is how you run the sample, how you process the sample, and how you generate the result or validate the result. And obviously, post-analytical will involve the reporting of the result, the interpretation of the result, and now in microbiology, since antibiotic stewardship is picking up, even the treatment, and sometimes even since we practice clinical microbiology, the diagnosis of the infection. Now, sample collection, the root, the quality starts from the root. So if we look at it, for us, the beginning point is sample collection. How good, you may have the best equipment, you may have the best microbiologist, you may have the best lab, but if the sample collection is not appropriate, you will never be able to generate a report which is of good quality. And sample collection also, you cannot make it very elaborate and non-cost effective. So it has to be a process in which it is cost effective. So the specimen collection, how do you collect it? How do you transport it? How do you receive this sample? And what rejection criteria do you set? The rejection criteria have to be realistic, practical, and which are referenced well in textbooks. So sample collection. So very important thing about sample collection is time of collection in microbiology. Many samples lose their stability if not transported. Urine culture, if not transported within 2 hours, you may not get good results. You may get a lot of commensal flora in it. So that is, time of collection becomes very important. The quantity of the specimen, the clinician will give you one small bit biopsy and will ask for a fungal culture, fungal microscopy, aerobic culture, gram stain, Zn stain. So the quantity of the specimen is very important. You can't do everything from a small piece of biopsy, but you need to economize, see, take a scientific call how you can do the maximum, but at the same time not compromise at the quality of reporting. The device of collection, it should be a sterile collection, it should be a leak-proof container, it should be an appropriate swab. We all know most of the microbiology samples are collected with the help of a cotton swab, and it needs to be put into a transport media and transported so that the swab doesn't dry off. You need to transport the sample at the correct temperature. CSF, most of the people think, oh, CSF, we need to preserve it the most. Let's keep it at 2 to 8 degrees centigrade. We all know for culture, CSF should not be stored at 2 to 8. Either it should be kept at room temperature or it should be incubated. So these are important things which we need to document in the sample collection manual, make it very clear to our technical team, as well as if you are working in a hospital, to your clinician and the nursing team, so that they are aware of what they are supposed to do. The sample reception, that is again an important part. A trained personnel, microbiology sample receiving is a specialized job. It cannot be done by everybody. You need to have a person who's competent to know what to accept and what not to accept. And yes, with COVID coming in, it is important they wear the appropriate PPE when they're receiving the sample, because there are implications and there are risks associated with this. Clearly define your rejection criteria: unsterile container, leaking container, wrong container, swab for tuberculosis, for a AFB stain or a fungal culture, aerobic culture. You invariably, the clinician wouldn't have realized. They would have collected a swab sample during the surgery and they would expect you to do an anaerobic culture. Please make it robust. Reject the sample. Vaginal secretions for gonorrhea, Foley's catheter tip, endotracheal tip, quantity not sufficient, 24 hours sputum sample for AFB, formalin samples for culture, heparin tubes for molecular tests. These are all rejection criteria. I have just enumerated the few top common ones. There you can elaborate according to your lab, what all tests you're doing, what is your niche sample type. A pediatric hospital may have a slightly different set of samples. High volume oncology center will have slightly different samples. So accordingly, define the rejection criteria. The other example is also define rejection criteria for a particular test, say anaerobic culture, let's say. As I said, swab is a rejection criteria. Other than that, you do not do anaerobic culture from midstream urine. You can't do it from gastric washing. You can't do it from a throat or a nose swab. You cannot do it from a superficial skin lesion. So these are the rejection criteria. Sometimes you may need to set test-wise, depending on what test you are performing. Then sample type. Commonest problem we all face, I'm sure if there are any microbiologists here, they would have faced swab versus aspirate. The clinicians tend to, since it's easier, probably convenient, they tend to send a swab sample, usually from a wound lesion or anywhere there is a oozing pus or any secretion. They tend to send a swab sample. If you can really see, your chances of getting the commensal skin flora around or the colonizer is always higher in a swab, and swab is not the best sample. Insist, explain to them to aspirate. If they're not able to aspirate, there is not enough pus there, ask them to send a part of the tissue whenever they are going to debride the area, or whenever they're planning to do a dressing, or whenever they're planning to do any kind of re-exploration, because swab is not an adequate sample for, especially to comment on sometimes. Appropriate labeling. This is again very important. Best sample collected, correct container used, but the patient labeling was wrong. So the wrong report may reach the wrong patient. So it's very important you have the correct identification of the patient. Source of the specimen. This is a common problem. The clinician thinks if I write pus, it is enough. If I write body fluid, it is enough. So we need to educate the clinician to give us the source of specimen. Where exactly was the site of lesion? You know, a pus sample from a gluteal region versus a pus sample from a lesion on the chest would be very different to interpret and to report. So that is why it is very important. And an initial prelim diagnosis sometimes helps. Probably the clinician doesn't understand that why a prelim diagnosis is helpful, but if we talk to them, we explain them many a times, the microbiologist is able to give a lot of insight into what could be growing and what could be the pathology behind it. Exactly the way the histopathologist, so histopathology and microbiology together can actually make a diagnosis sometimes for the clinician. Antibiotics being given should be mentioned very clearly. Other investigations requested, if mentioned, it becomes so where it is not an open lab, the labs are separate, probably a clinical correlation becomes very, very easy. The other problem which we invariably face in the labeling of the bottles is when the labels are placed wrongly. So train your staff not to place on the automated system to put the label on the barcode, how to label. So these are very basic small things, but these are a part of the Iqc plan when you make, where to put the label, how to put the label, when to put the label, what all should be there on the label. So these are important points. Now coming to the analytical process to be included. Analytical process in microbiology, obviously as it says microbiology, it starts from microscopic examination. Then obviously you process the specimen, then you do preliminary identification of the bacterial isolates as well as the fungal isolates, you interpret the cultures, you put the antimicrobial susceptibility, and again, I am again emphasizing, like in the pre-analytical, even the analytical process has to be cost effective, because as soon as it goes out of cost, quality becomes a problem for the management, for you to implement, and for you to justify. Now coming to, since the first step in the analytical phase of microbiology was stains, so QC for stains. First important thing is, if you're preparing the QC in-house, it should be clearly labeled, dated, and stored correctly. If you're buying commercially QC, you need to again choose the vendor properly. You need to verify the performance of the stain before you choose the commercial stain. And again, the same thing, it should be labeled, dated, and stored. And in both the circumstances, the expiry date should be mentioned. Most of the commercial stains would have an expiry date. The challenge comes with the in-house stains. So in-house stains, you will have to work out, prepare, and define your own expiry date. And it should show clearly, your SOP should clearly mention when to use a stain and when not to use a stain, if there is any turbidity, decolorization, any change in consistency of the stain, it should immediately be discarded. It should be checked at regular intervals. And at regular intervals, whenever you prepare a new batch of stain or you receive commercially a new batch of stain, you need to put your controls, check the performance, and do the staining. Smear in microscopy, stain is one part of it. Smear is another part of it. The smear has to be appropriate. It should not be too thick. It should not be too thin. CSF smears should be either centrifuged, the sample should be centrifuged and prepared, or CSF smear should be double smearing. Similarly, the tuberculosis ZN stain should be thick, should be such thick that you can breeze a newsprint under it. It should not be very thick. So accordingly, it is important for you to see. Similarly, when you do gram stain, when you do ZN stain, decolorization should not be incomplete, should be appropriate. So for this, the person who's performing the test, this is the personal where it comes, where they need to be trained regularly, their skills need to be evaluated on a routine basis, their competency needs to be checked for their performance. So you need to incorporate that in the Iqc plan as well. So, and grams, how do you check the QC? I said you put controls and check. Where do you put the controls? How do you put the controls? Look, all these stains which are used should have a daily control, preferably on the slide on which you're processing the sample. The control should be on the same slide so that the control gets the same treatment as your specimen. Control slides can be prepared in-house or they can be manufactured. Preparing your own slides, you can take a 18 to 24-hour culture of a known gram positive and gram negative, prepare an emulsion of that, and you can prepare the control slide and keep it. You can make it fresh every day, prepare it with your specimen. QC of strains, the quality of the sputum samples is important. I have just taken an example of sputum, but you will have to define it for different specimens. I am not going into details of each specimen, but in sputum, you have an basis microbiology, microscopy. You have an acceptance and rejection criteria for sputum. Follow the acceptance and rejection criteria. Mention clearly what is your acceptance criteria. Say if you have more than 25 squamous epithelial cells under low power, you would reject it. The second criteria could also be 10 squamous epithelial cells per low power field, and whereas including pus cells. So you can define your you can take any of the classifications, standard classifications, define it in your SOP, and you need to have an acceptance criteria wherever microscopic acceptance criteria is defined. Now, in strains, you need to have QC strains. How will you check it is performing properly? It just can't be any E. coli or any staph. So you need to procure ATCC strains. You need to maintain the ATCC strains, and different ATCC strains have been defined in different standards. I have just given you a few examples here, and you can take any standard. You can use the CLSI, you can use the UCAS standards, you can take any standards or any standard textbook, microbiology textbook, which defines which strain should be taken as QC. Culture. Just growing it, plating it on any media is not enough. You need to have the correct, appropriate media. Many a times, Proteus, people tend to Proteus, you need to isolate. People will plate it on blood agar and try to isolate. Proteus, example, best media would be clad to isolate Proteus to prevent swarming. So you need to choose the correct media for the correct sample. For sputum, you need to have a chocolate agar media because you need to have in your mind that it could be Haemophilus influenzae for CS. Similarly for CSF, so the correct appropriate media is very important. Choose the correct temperature, especially in antibiotic susceptibility. Even for organisms, there are organisms like Listeria, which may not grow well at 35 degrees. There are Mycobacterium tuberculosis, non-tuberculous mycobacteria, which do not grow at 30 degrees. You may need to incubate the media at 25 degrees centigrade. You need to have your fungal cultures. They require a correct atmosphere and correct incubator. You need to have a BOD incubator for your fungal culture. You need to maintain the temperature at 25 degrees centigrade. So these are very important factors. You should know for which organism, what temperature is required for you to isolate and for it to flourish and grow. Commercial media. Now, since we have manpower issues, we depend a lot on procurement of commercial media. So when you procure commercial media, when you receive the sample, you need to see whether you have received it at the appropriate temperature, the physical appearance of the media, no damage, no cracks, the media is not falling apart, no visible contamination of the media. And yes, the most important is obviously, since you're commercially procuring it, the expiry of the media. Once you do you procure or you prepare the in-house media, you need to check the performance of the media. The performance of the media is obviously, if it's dehydrated media, you need to see how you're preparing, the pH of the distilled water, the growth characteristics of the media, the physical appearance of the media, and the most important is the volume you dispense onto a 9 mm plate. How thick is the media? Too thick a media is a problem, too thin a media is a problem. How do you store the media? After preparation, how you label the media? You need to label an expiry date, you need to name the batch on which it was prepared, you need to store it at the correct temperature, and yes, sterility of the media batch check. You need to put a batch into the incubator, see whether the sterility is whether there is any contamination of the media. And the next thing is to see the media intent of the media. Now let's take an example. If you see the picture, blood agar. On the blood agar, the reason we put on blood agar is it's an enriched media. Other than that, it's also differential media. We need to demonstrate what kind of lysis. So if your media is not able to differentiate between beta lysis, alpha lysis, and no lysis, then there is a problem. So you need to check the performance of the blood agar with the appropriate strains and see if your blood agar is performing well. Similarly, McConkey's media, you look for lactose fermenter, non-lactose fermenter, and see whether your media is performing well. So accordingly, each media will have its own controls and checks, some of the common checks for the media I have highlighted here for the different medias and some of the biochemicals, and we need to check. Ideally, there should be one. If there are two kinds of properties, we should have two kinds of organisms which demonstrate one of the each property, and similarly, and if there are more than one, then you may need to use more than 2 QC strains. Streaking. There are different ways in which you can streak the plate. Usually I say it is a skill, it's an art to streak. Streaking is like a painter's skill. If you are unable to get good streaking done on your media, believe me, microbiology will never be successful. So a bad streak versus a good streak is a part of IQC in microbiology. Some common tests, if you're doing conventional biochemistry, biochemical tests, you will need to put the common biochemical tests are catalase, coagulase, indol, methyl red, oxidase. So for each of it, you need to have the appropriate controls, and all these controls should be freshly subcultured and used to check the performance of these tests. Usually there is first, let's take the example of catalase. So catalase 1, you can use Staphylococcus aureus as the positive control, and the negative control can be Enterococcus faecalis. Similarly, for coagulase, you need to have Staph aureus, and you need to have a coagulase Staphylococcus epidermidis as its control. So for all different tests, there are different controls mentioned. Again, I would say follow any standard textbook, any standard guidelines which you would want to follow and document. Similarly, antimicrobial susceptibility, it's very important to see what is the quality of the disc which you're using. If you're doing a disc diffusion method, you need to see whether the culture media, the Muller-Hinton agar is correct, whether the discs are stored at the correct temperature, and the content of the antibiotics is satisfactory. And how do you do that? Usually we do not put a QC for the susceptibility on a daily basis. Once we validate, we do a 3 to 5 days daily QC validation to shift to a weekly QC policy as per CLSI. Here you put the antibiotics in 3 replicates for 5 days, see the performance. If there are no outliers, you can shift to a weekly QC. And then every week you check the performance, you follow the CLSI guidelines to check for a particular strain. Say if you have put an E. coli, ATCC E. coli 25922, then you need to see what is the performance criteria of E. coli for that particular antibiotic. Let's take an example as meropenem. The CLSI guidelines define that, check that what is the acceptance criteria, and pass your QC. If your QC is not satisfactory, document, prepare in your IQC plan how you will do the corrective action. When you do the susceptibility, it's very important that you place the antibiotics at an appropriate distance. Avoid overlapping of zones. The inoculum 0.5 McFarlane should be prepared with in the most diligent way, because slight difference in the McFarlane can change your intermediate to resistant and your intermediate to sensitive, and in fact sometimes even you're sensitive to resistant. So be careful about it. Measure the zone precisely. The zone, don't leave it on estimation. You know, that's a common error. People just look at the plate, they do not use a scale to measure or any kind of measurement system and say that this is susceptible, this is resistant. So please interpret, see your chart, whether it is, what does your CLSI say or your UCAS say, interpret the zones according to the standards. Keep the antibiotics before you put it on the disc diffusion plate. Get it to room temperature. Do not take it out directly from the fridge and put it on the plate. Incubate the plates for the appropriate time. Like for Staph aureus, you need to put it for 24 hours, but for the others, most of it is 16 to 18 hours. Incubate it at the correct temperature, and please do not incubate it in CO2 when not recommended, as it impacts the disc diffusion. If you look at it, this is how you interpret. You can use the CLSI guidelines. You can, now it's the 31st edition which is there. I have not pasted it. Now you can use the UCAST guidelines as the European Committee of Antimicrobial Susceptibility. It is freely available. You can download it on the net. Then how to decide the antibiotic QC? You need to, I've told you, you can do a 3 to 5 day study, or you can do 15 replicates plan, or you can do a 20-30 day plan and see and shift from this to a weekly QC plan. Then distribution ranges for all the different antibiotics are given here. As I said, your antibiotic should fall in that range. If it is not falling in that range, then you need to, this table is available on in the CLSI, where it says very clearly, if you've used this QC zone and if your zone is too small, what do you need to do? If your zone is too less, what do you need to do? So you can see this table, interpret and take your corrective actions. Instruments. I spoke about the staining, the culture. Now the instruments which you use, the microscope, it is important you do the daily maintenance, cover the microscope, get a preventive maintenance done 6 monthly. The weighing balance, calibrate the weighing balance, do a daily maintenance. The use of the container which you use to weigh, it has to be zeroed, it should be clean, and it should be handled properly. Refrigerated and deep freezers, maintain the temperature log, do a daily maintenance, prevent frosting if you do not have a frost free, and temperature record should be maintained, if preferably on a data logger. If not, at least it should be monitored on manually for the instruments. Hot air oven, do a daily maintenance, check your biological indicator performance, your bacillus atrophius. So these are the things which you need to do for your instruments. Your similarly glassware, the centrifuge, all need to be calibrated. The glassware also, the ones with which you measure, should have a calibration certificate. Just don't go by that this measures so just don't go by it that the glass measures and we'll accept it. It's not that. The measuring cylinder, the measuring beakers have a certificate which should be procured from the vendors, and ensure when you're washing the glassware, that is very important, because we give the wash or the glassware to be washed by the housekeeping staff or the helper, the lab aide. So how they wash it, are they able to get rid of the detergent? Because all this will impact the pH of your media, the pH of your buffer, the pH of whatever reagent or stain you're going to prepare in that flask for the measuring. And do not store sterile glassware for more than 1 month. If you plan to store, re-sterilize them, put them back into the hot air oven and sterilize them. And the water bath, check the water level of the water bath, clean the water bath regularly, don't let a biofilm be formed there. And similarly, the incubator should be clean. And if you're using an incubator, CO2 incubator, and you have a water tray at the bottom, ensure that it is clean and the cleaning frequency is mentioned. And you have checklists on each instrument to check the performance of the instruments. Similarly, autoclave and the pipette, autoclave daily chemical indicator, weekly biological indicator with the Bacillus Thermophilus, and obviously the temperature and pressure records of autoclave are important. For pipettes, calibration and handling. Pipettes, the most important is train your staff. Do not presume that the staff know how to handle the pipettes. Train them how to adjust and where to leave the pipette once they have finished. For the adjustable micropipettes, it's very important that they do not leave it at the lowest level and harm the spring. So these are things which need to be taken care of, and it should be a part of your quality plan. Atcc strains. I have been talking about use of Atcc strains for checking the performance of the media, of the stain. So maintain on a non-selective agar plate and or slants up to 4 weeks at room temperature, but dispense them. Avoid repeated subculture of these strains. Maximum passage should be 5 passages, that is 5 times subculture. Usually what you buy commercially will come in 1 passage or 2 passages. So accordingly, plan your storage practice. Store your ATCCs in -80. If you do not have -80, you can preserve it on agar slants and agar stabs. But there you cannot preserve them for longer. When you're using an automated ID system, again, the QC initially needs to be done for 3 to 5 days. And if it is satisfactory, then you need to then you can go ahead with a weekly QC plan. The criteria for acceptability, generally 1 out of range result per quality control is needed for an acceptable result. At least 1 outlier is acceptable. More than that, you will need to troubleshoot, and you may need to repeat the process. I will go very briefly on the molecular part of it: test ordering, analytical, post-analytical, again, informed consent, how do you collect it, your barcode, labeling, that all remains same as microbiology. In the analytical phase, obviously here, the order verification, the nucleic acid extraction, the calibration, the controls, how do you perform the test, the QC, and the result verification part. And the interpretation, obviously you have the interpretation, verification, the results on the LIS, because quite a few of the molecular tests are interphased, then treatment decision and the data retention. So obviously the accuracy, precision, analytical sensitivity, the analytical specificity needs to be determined, because if you do quantitative HBV, HCV assays, you need to decide on what would be your analytical sensitivity and determine the limit of detection, lower limit of detection, and validate your assay before you start testing. So these are all a part of the Iqc plan for a molecular biology lab. I'm not going to go into detail, I'm briefing, because this itself is a topic, but this would be incomplete in microbiology if I don't at least make a mention of it. So different ways in which you can do it. I'm not going into the details of these, but yes, you need to do obviously the accuracy study. You need to do the precision study, where you do it over with different replicates for at least 3 replicates over 5 days to see how it is performing, and obviously the accuracy test. And yes, if you are reporting quantitative values, you will need to do an analytical sensitivity also. So now, since we have most of the molecular tests are commercial, and we can, some labs also pool these samples. COVID, we all have seen there has been pooling of samples. So it is important that the results are reproducible. Even if you pool them, then the statistical analysis of the QC results is important. You need to monitor the CV percentage. You need to plot it, serially plotted, and the Levedenics chart needs to be prepared. And yes, and you need to follow the Westgard rules, wherein you say whether the QC is passing, what is the passing criteria. In molecular, there are different passing criteria. For you may, if it's a quantitative value, you'd say take a 0.5 log variation, and similarly you can have a CV percentage for the passing criteria for some of your semi-quantitative assays. Then the other important thing is, after you make a QC plan, still there may be QC variations, there may be QC failures, where your say a gram stain QC did not pass, your antibiotic susceptibility did not pass. I had shown you how you can troubleshoot your antibiotic susceptibility through the table which I showed you, where the zone is big, zone is small. So similarly, you need to do a root cause analysis. You need to reach to the root why this happened. Iqc plan where you do not give importance to the root cause analysis is futile. You can have a plan, you may implement it, but if you do not work on it, it's for the sake of just documenting it, it's of no use. So microbiology, it will be multifactorial. So each component should be worked up. As I said, the media, the reagents, the instruments, and the person who's performing it, since most of it is manual. In molecular, it could be a contamination of NC, failure of the positive control, the instrument not functioning properly, the reagent not being appropriate, you not being able to store at a particular temperature. Serology also is quite similar. So identification of the causal factor, role of pre-analytical variables is very, very important. Most of the errors happen at the level of pre-analytical. It almost contributes to 60 to 70% of the errors. Then comes the analytical, and then later the post-analysis. So elucidation of the underlying root cause is very important. What happened, where it happened, when it happened, why it happened, how it happened, and who. So these are all questions which should come. There are different ways of doing the RCA. You can do it by the YY technique. You can do with the where, when, what, the who technique. So there are different ways, but you need to do a root cause analysis. So I would wind up my talk by saying success in failure. So if you do not have an Iqc plan and you do not fail and you do not do RCA and kappa, it's a futile attempt. So failure is an opportunity to begin more intelligently. It was very well quoted by Henry Ford. So we have to learn, we have to have a plan, we need to do the corrective action and then move
ahead.
All of you will agree with me, this hematology is a very important branch, and most frequently asked investigation is CBC or other hematological investigations. What is the purpose of our lab? For a clinician, they expect a timely report, that is, we are maintaining turnaround time, and which is correct, that means accurate and meaningful for them. Whatever units we are using, whatever way we are presenting these reports, this should be meaningful for them. They expect a reliable and reproducible report. They can take decision on these reports, and we have to keep ourselves updated with the advancing technology. And if we see what is most important in our laboratory, people who are working in our laboratory, they should be qualified, well-trained, and competent. What is competence? Ability to use acquired knowledge and skill in practical situation. So there are various ways of assessing this competence, and people should participate. As you are participating in this CME, people should participate in CMEs, seminars, various training programs to update their knowledge so that they can use latest technology in their laboratory. And also very important, and you must have seen in our QC in microbiology, biochemistry, and histopathology, equality of the specimen is very important. A well-filled test request form is important. A correct specimen, correct volume in correct container. This should be first collected and then labeled. And what should be the content of the label, that also you have to define so that you can trace a particular sample with the test request form, and ultimately you can reach up to the patient. And after collecting, this should be properly mixed, not very vigorously or not too lightly, कि some clot may appear in the sample. Then it shall be transported to the laboratory, keeping in mind that you are transporting at appropriate temperature within reasonable time frame, keeping in mind integrity of the sample as well as safety of the person who is carrying those samples. Then you are receiving samples in the laboratory and you are checking certain things, and good phlebotomy training is very important. When you are receiving reagent in your laboratory, you shall have some properly documented system, what all you will check at the time of receiving sample. Then you are storing samples under defined condition, and you are performing lab acceptance testing. For peripheral smear, you shall have documented procedure. For this Leishman stain, etc., for ZL stain, gram stain, for qualitative test like if you are performing HbA1c, HCV, HIV by card test, or for your quantitative test, how you will accept a reagent before using that for patient testing. You shall have well-documented procedure and acceptability criteria for that. How you will carry out, you can take the help of your company people, but as per requirement of ISO 15189, these things shall be properly defined. When we select a test, you must have seen during COVID-19 time, people were talking about this particular test. Diagnostic sensitivity is okay, but it is not specific. You must have seen in relation to your COVID-19 card test. It has very good positive predictive value, but negative predictive value is not very high. What is the meaning of all these terms? Diagnostic sensitivity means Siddhya, please unmute yourself. Or Shankari Shanoy, please unmute yourself. Yes, Shankari, am I clearly audible?
Yes, sir.
Okay,
Yes.
right. Diagnostic sensitivity means out of 100 cases of a particular disease, in how many cases the test is coming positive. It is coming positive in 90 cases. That means diagnostic sensitivity is 90%. Specificity means in out of 100 cases who do not have a particular disease, in how many cases the test is negative. Suppose in 100 cases who do not have a particular disease, if the test is negative in 95 cases, the diagnostic specificity is 95%. Positive predictive value from the test perspective. If a test is positive, what is the possibility of having that disease? Negative predictive value. If a test is negative, what is the possibility of not having that disease? And utility of test means, in addition to these things, what is the cost of a particular test? How much is the turnaround time? What is the cost of a particular test? All these things matters when we are deciding about the test utility and whether it will affect the decision on a particular patient or not. Then instrument comparison. When you are evaluating a particular instrument, what you have to see, what are desirable characteristics, what all you are expecting in a particular machine. Your desire may be it should have a throughput of 100 tests per hour. In hemoglobin, precision should be around 2%, or there should not be any carryover. So these are your desires, desirable characteristics. Performance specification, what company people they are offering you. If suppose they are saying we have two machines, one has throughput of 75 tests, another throughput of 125 tests. So these are performance specifications. Now you're deciding about a particular machine, and then you are verifying in your laboratory, you're confirming their claim, confirming their specifications. Okay, I have selected a machine of 75 tests per hour throughput. Whether I am getting this throughput or not, these are performance characteristics. And you are comparing a new machine with already existing machine in your laboratory. Results should be comparable. If suppose you have two machines, you cannot say on this machine hemoglobin is 12.8 and other machine is 10.2. So when we are comparing, what is the method of comparing? This regression analysis. In this we calculate correlation coefficient, and this is available on Westgard website, a particular calculator. You are submitting data of your old machine and data of your new machine, and they calculate a correlation coefficient for you. If this correlation coefficient is more than 0.9, correlation is good. If it is more than 0.95, correlation is excellent. It should be as close to 1 as possible. And many times we use these terms: validation, verification, calibration. What is the meaning of these terms? See, validation means somebody is claiming something. Verification means confirmation of the claim. And generally we say validation is at the level of manufacturer and verification is at the level of user. Because these company people, they are claiming, they are coming to you. On this machine, you can perform these tests. You will get a throughput of 80 tests per hour, or whatever they are claiming related to specification, related to precision, related to carryover. All these are their claim. And what is the basis of these claims? They have performed a lot of studies in their R&D lab, research lab, and they have taken the help of some users also. Can you please submit your data to us? And after that, they are coming to one of you. Yes, sir or madam, we have developed this machine. These are the performance specifications. You are saying, okay, I am happy with that. But first I will confirm in my lab whether I am getting these, whatever you are claiming or not. So when you are carrying out some studies in your laboratory to check their claim, this is called verification. And if suppose you are developing a method, suppose you are saying, I am using this ZN stain since so long, I will develop my own stain. I will not use Zn stain. Shankri Sharma may say, I will develop SS stain. Now she is comparing results of this SS stain with the Zn stain. And if the Zn is negative, she is comparing with the culture and some molecular study. And she is saying this is as good as Zn stain or maybe better than Zn stain. Whatever she has done, these are supportive evidence in favor of her claim. These are validation study. And if suppose someone else, maybe one of you, want to use the same stain, maybe Dr. Ravi Gautam. Now he is saying, first I will check whether this is comparable to Zn stain or not. Now he is checking in his laboratory. He is not claiming anything. He is just confirming the claim of Shankari. So what he is doing, he is confirming claim. You can say this is some sort of verification in his laboratory. Remember one thing, same person cannot do validation, verification both. Either you are carrying out validation or you are carrying out verification. And calibration is method of ensuring the desired performance of equipment. What is your expectation with the pipette, thermometer or centrifuge? They should measure the volume, whatever these pipettes are designed for. They should measure the temperature, whatever it is designed for. Same is your expectation with this simple instrument like scale. Your measurement should be correct. And centrifuge, your measuring speed, they should be correct. Otherwise, if suppose you are setting a centrifuge at 5,000 RPM, it is rotating at 10,000, it can generate more heat and which can affect your results. Similarly, what is our expectation with our analyzers? They should give us correct results. And for this, we are calibrating them with the help of calibrator. And these calibrators shall have metrological traceability. If suppose it is written on the calibrator 100 milligram per dl, suppose calibrator of glucose, you are asking company people how you derive this value 100 milligram per dl. Now they are saying we analyze this as is unknown sample 100 times with higher reference material. Okay, what is the guarantee? Value written on that higher reference material is correct. We analyze with further higher reference material. That way they are reaching to national international standard. This mechanism by which our results are traceable through this calibrator to national international standard with unbroken chain of comparison is called metrological traceability. What I feel, understanding of these terminologies should be as clear as possible. Now, when you're evaluating a equipment, first see, you have adequate, well-maintained space. And what is the quality of service you will receive? When you're buying equipment, how much training is required, whether in your city, in your laboratory, your staff, because our country is such a big country and at different places, you may not get the same quality of service by the company people. Now, what is the extent of training required and whether our people will be able to understand those things or not? Usefulness of instruction manual, about clarity in the instruction manual. Then safety requirements, linearity. What is linearity? What is the maximum value you can report without dilution? Check linearity also, precision. Results are close to each other when you are testing multiple times. Carryover, a low value sample is not affected by previously run high value sample. And you are using a reference method with already established method, performance of the machine in a class, analytical sensitivity, and analytical specificity. Analytical sensitivity we use in two contexts. One is sometimes we say lower limit of quantitation is same as analytical sensitivity. What is the maximum value we can quantitate? But if you read your Henry, and many other textbooks, now they say for that we have down lower limit of quantification, you can say lower limit of detection. Analytical sensitivity is what is the minimum difference in result you can appreciate on a particular machine. Suppose there are 3 machines. One is measuring hemoglobin, 12, 13, 14, 15. Second, 12.1, 12.2, 12.3, 12.4. Third, 12.01, 12.02, 12.03, 12.04. Analytical sensitivity of first machine is 1 gram per dl. Second machine is 0.1 gram per dl. And third machine is 0.01 gram per dl. Specificity, it is measuring intended analyte only. You must have seen in our 3-part differential, nucleated RBCs are also counted as leukocytes because they measure on the basis of size. These are counted as lymphocytes. That means these analyzers, 3-part, these are not specific for TLC. Nucleated RBCs also counted as leukocytes. Analytical time, how much time it will take to measure. Then one thing is analytical time. Suppose analytical time is 20. Analytical time is 2 minutes. That doesn't mean in 1 hour you will measure 30 samples and in 2 hours 60. You may need some washing cycle. You may need some rest for the machine. How much sample you can assess in 4 hours or 5 hours. So that you have to see. One thing is analytical time and then throughput time. Then reliability of the instrument, what type of service you are getting, and also see cost per test. When you are estimating cost per test, don't see only reagent cost. See how many controls you will run. Some part of the cost of the control will go into the cost per test. Then cost of the machine, cost of the AMC, CMC, all these affect our cost per test. So when you are calculating, see all these things. Then acceptability of the machine and technology by the staff, that is also very important. And when you're using machine, a good maintenance of the machine is also very important. Only then you will get good response from the machine. So whatever manufacturer is recommending, at least follow that. Whatever they are recommending for daily maintenance, for weekly maintenance, for monthly maintenance. And once in 3 months or 4 months, their company people are coming for the preventive maintenance and take official AMC or CMC for the better service of the machine. Safety protocol is very important for the lab. Prepare lab safety manual, physical hazard, chemical hazard, biohazard, proper disposal of biomedical waste. You shall have clear-cut guidelines for all these things. These things vary from laboratory to laboratory depending on type of reagents you are using, type of facility or place you are using. Dr. Anjali Manocha discussed all these things with you. You shall have well-documented procedure for internal quality control. And metrics, environment of the sample should be as close to patient sample as possible. It is not like that in deionized water, you are adding glucose and using that as a control. Should be resemble as close to patient sample as possible. And you are plotting Levy-Jennings chart and Westgard rules, she discussed with you. And in hematology, what happens? Stability of the control is very less. You cannot calculate mean and SD, which you are using for the next month. Stability is around 20-21 days with most of the machines. So what you can do, you calculate CV%. In 21 days or 20 days, suppose you are getting 30-40 data points, you calculate CV%. And next month, even when lot is changing, but there should not be significant variation in the data. You can compare coefficient of variation. Suppose for 6 months, your CV is 2.1, 2.0, 2.2, 2.1, 2.0, 1.8, like that. And suddenly 1 month you are finding CV percent 3.6%. That means something has happened. Why CV has increased so much? Bull's testing algorithm. This is not alternative of internal quality control, but what you can do, you can take the data of 500 samples and you calculate mean of hemoglobin, TLC, RBC and platelet, these quantitative parameters. Now you have these means, and then after for every 20 samples, or you can decide some number as per your requirement, you check the mean value. The mean value shall not significantly differ, significantly vary from the previous data. If something is happening, you see, there shall not be any special clinic on that day. Suppose on a particular day you are running anemia clinic or leukemia clinic, then you may have different averages. So you have reason for that. Otherwise, it should not vary significantly. And see change in the sample. What is the difference in the result? Morning, evening, or today and tomorrow? So that shows sample stability. You are storing sample properly or not. In Iqc, Z-score evaluation, in quantitative Iqc, and comparison of findings in qualitative Iqc. In hematology, or you can say any other laboratory, review of patient results is very important. And this is one of the requirement of your standard also, clause 5.7.1, delta check. Delta check comparison with the previous results. And you also see there are no interference with the interfering substances, correlate results clinically. In hematology, also see histogram, a good understanding of histogram, and scattergram is very important. And if you people are interested, so we can arrange some program on the interpretation of histogram and scattergram also. Interpretation of numerical data. Normally there is a relationship between hemoglobin and hematocrit 1:3, RBC count and hemoglobin 1:3. If there is some variation, then see what is the reason. If it is showing some flags, proper interpretation of that is important. After reviewing patient result, these shall be posted correctly. There shall not be any typing mistake, or if you are uploading on your website, there shall not be any typing mistake. Maintain patient records properly. Monitor turnaround time for routine as well as urgent tests. Take customer satisfaction, develop some feedback form, and must ensure you are maintaining your equipment properly. And we can see this simple test, per smear. Now you can understand how quality is important everywhere. See, someone is writing this feedback form is showing diagnostic day 4. It is okay. You fill this feedback form. It is okay. I think my team forgot to change this. In peripheral smear, a preparation of good peripheral smear is very important. A good staining is very important. A good appreciation of morphological findings is very important. And correct interpretation of these morphological findings is very important. All these things are important. This is a very simple test which all of us perform in our laboratory. And similarly, for each and every test, we shall have some system how we will check quality of that particular test. Now see what I'm trying to tell you. This 35-year female came for annual health checkup, but there was some difficulty in the sampling. In 2 ml EDTA tube, we collected only 1 ml sample. And these are the parameters. And clinician thought this patient has normal hemoglobin, MCV is low, 72. This patient may have some hemoglobinopathy. He asked for HPLC and also iron studies. Everything was normal. And when this patient was tested again, even that CBC was normal. What was the reason? In half-filled tube, because of the excess EDTA, there was shrinkage of red cells and MCV was reduced. Now see here, hematocrit is 33.1, hemoglobin is 13.5. This ratio is not maintained. Hematocrit is calculated parameter in our analyzers. MCV is a measured parameter, hematocrit is a calculated parameter. What the laboratory should have observed, this ratio is not maintained, there is some reason. And on this root cause analysis, they would have reached to this. So this is very important. And 80 to 85% errors occur during pre-examination phase. The good control on pre-examination, very important. See, we talk about automation. We have this machine is available only in our laboratory, all across the country, or all across the city, or all across the state, or maybe all across the globe. But what is more important, 80 to 85% errors are occurring in the pre-examination phase. A good control over that is very important. Now in this healthy person, TLC low, platelet low, hemoglobin low, pancytopenia. What is the solution for that? Go for bone marrow. But technician noticed clot in the sample. When they collected repeat sample, everything was okay. In this case, TLC high, they thought it is some myeloproliferative disorder. But when it was retested, everything was normal. Sample was highly lipemic. When sample was observed, and that lipemia was causing pseudoleukocytosis and pseudo increase in the hemoglobin. Low TLC, low platelet, low hemoglobin, again pancytopenia. And what was the reason? You can imagine the technician collected blood from the same arm where the patient was receiving IV fluids. Again, where is the problem? In the pre-examination phase. Now see, hemoglobin low, TLC lower side of normal, platelet normal, MCV 88. And what is the normal MCV? 80 to 96. They thought it is normocytic normochromic anemia, and this is normocytic. They ruled out nutrition deficiency. And our analyzers, they measure the mean value of the size of the red cells. What was the reason here? It was a case of dual deficiency. And when this patient received hematinics, there was improvement. The correct interpretation is also very important. It is not only technical part. Pre-analytical and correct interpretation, both are important.